All right, so we're going to start with the care of a neurological patient presented to you guys by the IndyVet Neurology Service, which is myself, Kaylee Howell, technician Melissa Ely, and other technician Ashley Gale. Our goals and objectives for this presentation are to review of common neurological patients and their specific care needs, identification of seizures and other episodes, intervertebral disc postoperative patients, bladder expression, commonly used medications, and medications with neurological side effects. Commonly hospitalized neurological patients. Things such as seizures, brain diseases, including idiopathic, infectious and inflammatory, cyst or hydrocephalus, as well as cancer. Things such as vestibular disease, idiopathic, ear diseases, infection, inflammatory, or neoplasia. Intervertebral disc disease, things such as surgical management as well as medical management, lower motor neuron patients, including myasthenia gravis. Seizures include many different causes, such things as single events, clusters, or status epileptics. Stages of a seizure include pre-ictal phase before the seizure itself known as ictus, as well as post-ictal, this after a seizure. Abnormal behaviors are possible, such as pacing, vocalization. Sedatives do not work for these patients. Head pressing, running into objects, as well as overreactivity to stimuli and aggression is known. What is a seizure? There are grand mal seizures, which would be convulsing, paddling, being non-responsive, urination or defecation during the event, as well as post-ictal behaviors afterwards. Focal or partial seizures include facial twitches not rhythmic, partial or complete non-responsive behavior. They can progress to grand mal seizures, including post-ictal behavior afterwards. Things such as anticonvulsants and benzodiazepines do help with this. Vestibular episodes, they're going to include thrashing or paddling, alligator rolling, being responsive, but may be stressed and appear less responsive. There's things such as nystagmus and head tilts can happen during these episodes. Opistance episodes include caudal fossa or the brainstem and cerebellum lesions, causing stretching of the head backwards and stiff front limbs, being non-responsive during this time. Cerebellar tremors include rhythmic tremors, especially during an activity, intention tremors, being responsive during this episode. Things such as syncopal episodes include collapse, falling over on their side, stretching out limbs and neck, being non-responsive, and having no post-ictal period. Anticonvulsants do not work for these episodes. Specific neurological diseases and the care required. A seizure patient, we want to be careful when a patient is post-ictal, as it can become aggressive or ataxic. They're not aware of what's happening around them as much. We should be monitoring them closely, but not in dog wards. We do place bells on these patients around their neck for monitoring. If on a CRI, it should be disconnected for less than 10 to 15 minutes at a time, as it can cause them to have more seizures if they're disconnected for too long. Post-ictal patients can have rhythmic movements like paddling, not seizure activity. Vestibular patients, it's not a seizure, so they will not respond to anticonvulsant therapies. Sedation such as trazodone and or acepromazine may be helpful with anxiety during this time. We do put extra padding in the kennel or the cage. We prefer to lay them on one side usually, and they do prefer that as well. May need to be hand-fed or offered water by hand, as they are not always aware of where it is located in their kennels. They may be nauseous or vomiting.
All right, so I'm going to discuss with you specific neurologic diseases and the care required. First, I will discuss with you intervertebral disc disease. These can be both neck and back patients. These patients should not be placed in top kennels. And basic post-op care would include checking the incision. We would ice the incision for the first 24 hours, and we do not place bandages on these incisions. As far as pain control, we generally keep these patients on a CRI for the first 24 hours. Do not discontinue until instructed by the neurology service. And then we would transition to oral medications after 24 hours. As far as sedation, depending on the preference of the doctor, we will generally do either acepromazine IV or dexmedetomidine. And then trazodone orally for anxiety. The first 24 hours, patients need to be very quiet. They can sit sternly, but should not be moving excessively. As far as handling post-op patients, it is crucial to follow the specific instructions on the smart flow sheet created for this patient. This will give you an indication on what and what should not be done for the patient during their time of recovery. Be sure to note any purple or red highlights. Those indicate something special is needed to be done. For example, patient may or may not be able to urinate on their own, no neck leads, and whether or not to pill the patient. Continue to handling post-op patients. Any neurological patient with the urinary catheter in should not be walked unless otherwise directed by the neurology service. All post-op patients will not be walked the night of surgery to allow them time to rest unless otherwise stated. With that being said, they should still have their bedding thoroughly checked regularly. When rotating patients, be sure to provide adequate support to the entire patient but paying close attention to the surgical site. Post-op patients will need to be sling walked outside to provide support and stability. To provide appropriate sling walking, not dragging or wheelbarrowing patient, may carry patient outside for the smaller patients. When walking outside, do not place a leash around the neck on any cervical patients. We prefer behind one of the legs. When removing a post-op patient from a bottom kennel, try and allow them to come out on their own rather than reaching in. For some patients, reaching in may cause them to anticipate pain or anxiety and lash out. Instead, try coaxing them out. If that is unsuccessful, you can slowly and gently pull on the blankets and the green rubber mat while keeping a hold of their slip lead. When placing patient back in cage, make sure to help them get comfortable so they are not just falling into the cage. Again, support and help with stabilization of the surgical site. When picking up or holding patients, do not pick up patients by the front limbs. Provide adequate support to the whole body. Prevent wiggling or thrashing. We do recommend a football type of hold, and make sure patient is in a neutral position. There are 2 links provided to show you how to do passive range of motion on patients. The first one is with the patient laying in a lateral position. And when you're doing passive range of motion, you do want to make sure that you are doing slow, deliberate movements. And the next video shows the patient in a standing position. So it's just going to be what's easiest for you to do the passive range of motion. And you're just going to be moving the patient's legs in their normal walking position.
All right, so next we're going to talk about bladder management. The proper technique in both catheterization and expression is important to prevent the trauma to the bladder wall as well as the urethra. A bladder that is too full can result in permanent apnea. Even if there is urine present in the cage or if the patient urinates outside, the bladder should always be palpated for size. This will help prevent that permanent apnea as well as to prevent the introduction of bacteria into the urinary system. If an animal is paralyzed, it most likely cannot urinate on his or her own. However, such as Dr. Mosine would say, if it can walk, it can pee. But some animals do need medications to help relax those urinary sphincters if they cannot go on their own. But first, before you do any of those medications, you do want to try expression. If you're unable to do that, Dr. Mosine usually likes to start with diazepam. So you'll give that, and then you'll wait 20 minutes and try the expression again. There is another medication called prazosin. That one's not usually used by Dr. Mosine, but in certain cases, it is needed. So how often should a bladder be expressed? Ideally, every 6 hours, but this is also patient dependent. If urine is present in the cage, or if the patient is continuously dribbling urine, that's considered to be overflow. So you should still palpate the bladder and try to express them, even if you're within that 6-hour mark or whatever the smart flow sheet says. If there's that urine present or you notice that they are continuously dribbling, then definitely try to express them. When expressing their bladder, be sure to support the patient fully and grab a helping hand if that's necessary. And depending on the patient's comfort level for bladder expression, this can be done while the patient is laying down or standing. Now, I know that we talked about the patient's comfort level, but this also is technician comfort level as well. So step 1 to bladder expression. Make sure that your patient is in a comfortable position. That can either be standing or laying down. In the picture to the right, you're going to see them laying down in a lateral position. If the patient is laying down, gently place one hand under the abdomen and one hand on the top in the same area. If the patient is standing, put a hand on either side of the abdomen. Hands should be placed caudal to the last rib. Step 2 to bladder expression. You're going to gently palpate the abdomen, slowly moving hands medially towards one another. The bladder is mobile within the abdomen, so making sure to start cranially and moving caudally to try to trap it within your hands is key. Step 3 to bladder expression. Once you feel the bladder, apply steady, even pressure with both of your hands. And then you're going to continue to gently press until the bladder is empty. You may have to adjust your hands during this time. As the bladder is emptying, you're going to have a harder grip on it unless you are keeping that steady, even pressure. Key points for medication administration for a neurological patient. For cervical spine, post-operative, or even if we're just doing medical management, we do not want to pill these patients because that could cause their injury to become worse. For thoracic and lumbar spine patients, whether that being post-operative or medical management, we want to avoid pilling and only perform if indicated on SmartFlow. Use 2 people if needed, one for pilling and the other for supporting the hind end to prevent thrashing or backing away. Some commonly used medications for anticonvulsants, these would be our rescue medications, so diazepam and midazolam. Diazepam can either be given IV or rectally. Midazolam can be given intravenously, which is IV, intranasal, or intramuscular. Both of these can be used intermittent or as a CRI. If using as a CRI, they need to be weaned off. You can't just stop those. But all of that will be indicated on the SmartFlow sheet. A technician should not be making those decisions without talking to a doctor first. For maintenance medications, we can use phenobarbital, levetiracetam, which is also known as Keppra, zonisamide, and potassium bromide. The most common side effects that you'll see is ataxia and sedation, and it's important to give medications on time. Some other commonly used medications, pain medications, typically we'll use fentanyl, lidocaine, gabapentin, tramadol, and amantadine. All of these pain medications can also cause sedation and ataxia. We have some miscellaneous commonly used medications, such as steroids, gastroprotectants. Some sedatives that Dr. Mosine will use is acepromazine and trazodone. Those also can cause sedation and ataxia. Also, anti-nausea medications, such as meropitant or meclizine. And then there are a few medications with neurological side effects. Enrofloxacin given IV can cause seizures if given too fast. Metoclopramide given IV can cause seizures and ataxia at high doses. And metronidazole orally or IV can cause vestibular signs at high doses or with chronic use. Now we do have some references there. That is actually where we got the pictures for the bladder expression if you're interested in looking at those. And if you have any questions after this PowerPoint, feel free to stop by our neurology room and we'll be happy to answer any of those questions. You guys do have a quiz that will need to be completed and returned back. But like I said, if you have any further questions, just feel free to stop by. Thanks.